Welcome to the Zeiss Ophthalmic Medical Education Summit hosted by Zeiss and Eyes on Eye Care. My name is Joe Panarelli. I'm a glaucoma specialist at NYU Langone Health, and I'm going to be moderating a session today with Doctors Jessica Steen and Anu Lau. And we're going to be walking through a few complex cases that take us through both the medical and surgical management of glaucoma, as well as some key diagnostic questions that many of us face when treating glaucoma patients. So thank you again for participating. I'm going to turn it over to each of the doctors to introduce themselves.
Hi, I'm Jessica Steen, an optometrist and director of the glaucoma service at Nova Southeastern University College of Optometry in Fort Lauderdale, Florida.
My name is Anu Lau. I'm associate clinical professor at the State University of New York and the instructor of record of the glaucoma micro-credential program here at SUNY.
All right, so the case that I'd like to bring forward for discussion, because I truly think there is a lot to unpack here, is that of a patient who's currently 60 years of age, and she was diagnosed with primary open-angle glaucoma in 1998. She was 36 years of age at the time of diagnosis. She was initially treated with timolol 0.5% in each eye, and she initially presented to our clinic about 10 years after the time of diagnosis on timolol, with pressures in this 18 to 20 millimeter mercury range. And at this point, we were not aware of her peak untreated intraocular pressures. She has thin corneas, central corneal thickness less than 500 microns in each eye. Visual acuity is 20/20. There is no afferent pupillary defect, and color vision's unremarkable. Now, systemically, she has medically treated hypothyroidism, and she is certainly not hypertensive. Now, if her max blood pressure measurement in our office, if you can call it a maximum reading, was 111/78 millimeters mercury. She has no family history of glaucoma, but potentially of note here, her mother has Alzheimer's disease. Now, for us that really embrace and actually utilize technology, I am still an advocate of traditional standard fundus photography. This is a technology that allows us to identify change objectively over time and manage patients really objectively over 10, 20, 30, 40 years. A technology here that certainly doesn't change. When we look at our optic nerves in 2010, we see inferior neuroretinal rim defect in each eye with a very subtle nerve fiber layer change. Superior temporal, there is also a subtle nerve fiber layer defect. We see early nasal step in each eye that's consistent with her optic disc appearance. And as we go through this case, we are going to see different types, different strategies, different patterns of visual fields. This just happens to be a 30-2 CETA-FAST that was performed in the right and left eye. Now, remember these days, early in nerve fiber layer imaging, we have objective, quantifiable data about the nerve fiber layer defect that this patient has. We see symmetric nerve fiber layer defect in the right and left eye, inferior, certainly greater than superior. And certainly interesting here, this was a time before the commercial widespread availability of ganglion cell complex analysis. So at this point, when we're talking about OCT analysis, it was all about the retinal nerve fiber layer. Now, if we move forward through this patient's disease course, we see clear functional change over time. We've lapsed about 8 years here, and now this is a 24-2 CETA standard that was performed. We see deepening of the visual field loss that now extends beyond that vertical midline. And if we really look at the paracentral defect in a little bit more detail on a 10-2 visual field, a 10-2 CETA standard, certainly we start to think about the functional considerations in this patient's case. When we watch patients for long enough, we know that disease progresses. But when we think about this patient's early age of diagnosis, relatively young age, and intraocular pressure readings at where progression has been identified in this 14 to 16 millimeter range, we really start to think about what else can or really should be done. So when we're looking at progression, we're really focusing on the visual field in this particular case. Mean deviation and that change in the mean deviation slope over time doesn't look as impressive as when we look at the visual field index. Now, I like the visual field index progression analysis for this patient because it does weigh those paracentral points more heavily, understanding that there is more functional implication in loss of the paracentral visual field versus those non-central points. So this particular case, she is truly an ideal patient to manage and to work with. She is diligent, she's aware of her disease process, and really understands her central role in chronic disease management when we're talking about medication and medical therapy. So she is as perfect as someone can be with adherence to medication. Her only lapse in medical therapy occurred when she unexpectedly left the country for longer than planned. So there was self-discontinuation of medication because she ran out of medication. By the time she came back to our clinic, she was off all medications for about a 4 to 6 week period, which really did allow us to better understand her peak untreated intraocular pressure, which was only 19 and 21 millimeters mercury, versus this 14 to 16 millimeter mercury range on latanoprost, dorzolamide timolol, and brimonidine. So, Joe, any thoughts on this case at this point? We have progressive disease at a relatively low intraocular pressure.
So many great pearls to unpack here. Really just a brilliant case, and one I feel like we all come across day in and day out. And honestly, it's the type of case that we lose a lot of sleep over for so many reasons. Are we doing too little, or are we doing too much for this patient? What is the right answer? And I'll start off commenting on a few things. The history, so important. Knowing what those untreated IOPs were, knowing about the family history, understanding the genetics in the family. Did anybody go blind? Did, first degree relatives, cousins, who else has the disease? Because remember, pressure is one of many risk factors for this disease. It is the only modifiable risk factor, but there are other factors at play. And I think we always have to take that into consideration, because patients, unfortunately, and I think families and even other doctors will feel that, well, if I control that pressure, the disease is going to be stopped, right? And that's not always the case. And I think that's what you have to sometimes understand, is that you could do diurnal curves on these patients with, eye care homes and see that the pressure is really, there is no volatility, but that patient may still get worse over time. And the question becomes, how do we change the curve that you're presenting here in terms of that visual field trend, that downward trajectory? And oh boy, I'm not going to pretend I have an answer to that. But one thing I do think is important, I want to ask both of you, look at the visual fields and the variability. I think one point that's important here is how much you have to repeat visual fields to confirm or refute progression. So how many visual fields are you doing a year on a patient like this? And what kinds are you doing? Because you did allude to it. There is some value to different kinds, and whether you're doing C to standards or C to fast or faster or the dash Cs. I mean, walk me through what you would do for this patient for your testing each year.
So in this particular patient, I've shifted to 24-2 C to faster at least once a year, and a 10-2 at least once a year. Now, we've really focused on functional measurements rather than running OCTs frequently on this patient, just because of her really long-term robust visual field data. It's really been the best way, in our opinion, to monitor this patient over time. But my typical, for most of our either new presenting cases in our clinic, or I am transitioning patients from a 24-2 to the 24-2 C to faster.
Anu, what do you feel about the reliability of the 24-2 C faster? Do you have any questions about that?
Yeah, that's an excellent question. So, historically, the way that I learned it was always the C to standard. That's exactly what we did, and that's how I was trained. However, there is data that sort of shows that, the C to fast, for example, if you have long-term data over time, and I think it was Dr. Crabb that showed this data, that the variabilities that you get from the C to fast or faster algorithms tend to even out. So, if you can only do one visual field, then sure, the C to standard, because of that double threshold bracketing, you get more accurate results. But if you're doing many visual fields over time, the benefit of that C to standard really decreases. And I think you can get some really good data with the C to fast and C to faster algorithms.
Well, Jessica, I agree 100%. I think this is a perfect case for a 24-2C for a variety of reasons. I think the key thing you have to remember is, you have to have a happy patient, because a lot of times the patients, the more testing you ask of them, the less pleased they are to do some of the testing. They skip it, they don't do it. So I think you have to be cognizant of all that. Yeah, it may sound good that, oh, I'd like to have 6 visual fields over 2 years because that's what they found in the collaborative normal tension glaucoma study. That's not practical. That's not what we're doing here. We need to find ways to keep our clinics running and to not miss things. And so I think that's just important. And I'm curious about now the structural testing, because what's interesting here, when you looked at these fields, we're mostly limited to the superior hemifield. And I might make the argument that I don't know what I can do to stop what's going on up there. My bigger concern is making sure that those inferior hemifields don't become involved. And I think that's where you have to be careful sometimes. My students sometimes will get too many 10-2s, and I'm like, hey, wait, zoom back. Don't forget, we want to make sure there's no beginnings of changes in those inferior hemifields, and maybe watching very carefully structural changes on the OCT. So I'm curious, how often are you getting an OCT in this patient?
So OCT has been a lesser priority, I'm not ashamed to admit, which has been about every 1.5 years on this particular case.
Yeah, and the main reason I'd ask is just tracking to see it. And again, maybe using some of the software analysis to see if there are some changes in the superior nerve fiber layer, to see if you can pick up things now on the ganglion cell analysis that maybe we couldn't see before. But I will also go back to a point you made. Man, the photographs, it's amazing what you can see. And the first thing I picked up were those nerve fiber layer defects that you pointed out so nicely. And that's really just hard to sometimes pick up clinically, no matter how perceptive you are, no matter what filter you put on there. Nothing really shows you quite like the disc photograph. Now, what's interesting here is how we're classifying this glaucoma. Is this POAG? Is this NTG? Is it a mix? And I think classically, when we talk about low tension glaucoma, there's one side of the camp that says, all right, low tension glaucoma, I'm thinking patients who have, vascular abnormalities, problems with autoregulation, Raynaud's, cold hands, cold feet, poor circulation, hypotensive at night. And then there are others who think that it's just all spectrum of one disease where there is probably some IOP volatility. I actually think there's like 2 separate forms of NTG. There is that former condition I was just talking about, and then there really is the latter, where I think there's a large genetic role to what's going on here. This patient has just something about their lamina cribrosa, something about maybe their CSF pressure that we don't totally understand, something about the gradient at the optic nerve head. I think we'd all agree. The only way to really fight this, though, I think, is to get the pressure lower. So I'm curious from you two, where do you go with topical therapy? What do you think about laser? Is it something we should pursue, or are you kicking this over to me here to think about doing a trabeculectomy? What are your thoughts? How far do you take this, and for how long?
At this point with this particular patient, progressive disease in the mid-teens, we did consult with a local glaucoma surgeon, someone that you know very well from your time in South Florida, who had advocated for trabeculectomy. Now, in this patient's case, at that point, she was underinsured and was concerned about the financial obligation, so had begged to try to defer surgical intervention with any other medications possible. So we worked with her. We talked about additional medical therapy, and we made the decision together to add notarsidil. So a fixed combination of notarsidil and latanoprost. We kept on dorzolamide timolol and brimonidine. And this has been about 3 years on this particular combination of topical therapy alone. And her intraocular pressure has stabilized at this 8 to 11 millimeter mercury type of range, which was surprisingly remarkable for this one medication change.
And that's kind of the claim to fame, I think, for these new Rho kinase inhibitors, is that, they really work well wherever you add them in your treatment algorithm. At least from some of the data we've seen from some of their phase 4 studies. And I've seen it, there's not many medicines that can get you to drop below your floor or that episcleral venous pressure. And this is one of them. And this is what I would hope to achieve with a trabeculectomy, is consistent pressure reduction in this sort of 8 to 12 range, which is not easy to do with our traditional glaucoma medications. And honestly, not something I'd expect to see with laser therapy either. So kudos. I think this is a great job.
So at this point, she's remained stable. To bring in our last type of visual field at 24-2C, see to faster. And as you said, paying very careful attention to the inferior visual field here at this point is unaffected or minimally affected. But we have a young individual who's shown progressive disease with paracentral functional damage here. So this is someone that, as we're watching her over these next, hopefully 30, 40 years, we certainly have a lot to think about in maintaining her pressure and maintaining her functional status here.
That's the key, I think, is looking at the patient's age. If this patient's 75 years old, I'm not nearly as worried. But you're talking about a patient who's only 60 years old, and with the way life expectancy has increased over the last decade or so, you have to be thinking, I need to keep this person doing well for a longer period of time. And I think that's what we sometimes forget, is our job is to preserve a patient's functional vision in their lifetime. And so, listen, they were doing okay. That rate of change wasn't that bad. I agree that we had to get a bit more aggressive because there was some change, but that's always the key. And that's where good conversation with the patient is so key, to ask them how they feel their vision is changing over time. Because believe it or not, the patients will know what's going on. They will always be able to, it's amazing. They can go within a few percentage points of that VFI of how much vision they've lost. I'm always very impressed with what a patient knows, even when it's something like, that visual field on the right. And, Jessica, I think we talked offline a little bit about thoughts on relatives of this patient and how aggressive to be if you are seeing this patient's daughter or this patient's son. I'm curious to my panel in the last few minutes we have here, how aggressive would you be with a child of this patient, who is maybe has a borderline pressure?
So in this patient's case, her daughter's 38 years of age. She has been seen every 3 to 4 years in our clinic with nerve fiber layer imaging, ganglion cell complex imaging, with an intraocular pressure in this 20 to 22 millimeter mercury range, untreated. Just recently, when comparison of her nerve fiber layer and ganglion cell complex showed change, so statistical significant, but really clinically significant, more than about 12 micron change in looking at the clock hour analysis, we made the decision to treat. She has thin corneas as well, but understanding her mom's disease course and trajectory, at this point, we are being relatively aggressive, and there is no visual field loss in the daughter, but trying to delay or prevent any functional change in this case, we have been aggressive.
I would 100% agree, and I would do the same. I think it's always the question. I think a lot of us sometimes are duped, even for patients with a normal pachymetry, into thinking that they have to have more significant pressure elevation. But if you look at the Baltimore Eye Study, the Barbados Eye Study, and so many others, so many patients come to your clinic with a pressure between 20 and 24 at diagnosis. And when you see results of classic trials like OATS now being carried out through 20 years, we see, there is a real risk of conversion. And I think, you got to be very careful, and you have to sort of weigh each of these risk factors a certain way in your head. And nothing beats your gut judgment when you're taking care of, one of these family members, and you just sort of get a certain feeling. You're like, now is the time. So I think that was a great case. Thank you so much. And I think we'll move on to case 2 and hopefully have another lively discussion here.